Although the accuracy of IOL calculation has increased in the past few years with the advent of the IOL master, refractive surprises still happen after an eventual cataract surgery. When we face an unexpected refractive occurrence following phacoemulsification with IOL implantation, we have several options: spectacles, contact lenses, IOL exchange, LASIK or PRK, Piggyback IOLs, CK and LTK. Since the options available were unsatisfactory to our patients at that time, Piggyback implantation was chosen as a means to correct results that were disappointing to both the surgeon and the patient in the following cases. Case number 1 is a 73-year-old white female who underwent uneventful phacoemulsification with implantation of a 3-piece silicone IOL model LI61U back in 2002. The patient was unhappy with the refractive result because she ended up a little hyperopic on her near vision eye. 2 months after the original surgery, she underwent a piggyback implantation of a 1-piece PMMA IOL with an overall diameter of 12.5 mm, with an ovoid optic with a rounded edge and a power of +3 diopters, resulting in a satisfying refractive outcome. 4 years after the piggyback implantation, she presented for a follow-up visit when she had 20/20 corrected vision on both eyes. The intraocular pressure and the optic discs were normal. A slit lamp examination showed fine pigment granules dispersed throughout the corneal endothelium. Neither Krukenberg spindle nor iris transillumination were present. Both IOLs were in the correct position. Gonioscopy revealed a wide-open angle and a trace of trabecular pigmentation. UBM examinations confirmed both lenses in the correct position. The anterior chamber depth was 3.756 mm and the inferior iris lens contact distance was 1.380 mm. The second case is a 73-year-old gentleman that also had an uneventful cataract extraction with an implantation of an acrylic 3-piece IOL model MA60BM in the capsular bag back in 2002. He also ended up hyperopic and underwent piggyback implantation of a +4 diopter IOL exactly like the one in case number 1. On his last visit in 2006, the slit lamp examination was completely unremarkable. We decided to perform UBM examination to compare the two cases. As you can notice, the anterior chamber depth is 3.883 mm and the inferior iris lens contact distance is 1.082 mm. Both IOLs are in the correct position, and although there is contact between the iris and the anterior IOL, there is no pigment dispersion. Compared to case number 1, the anterior chamber is deeper and the iris lens contact distance is smaller. Piggyback implantation was originally devised by Dr. Johnny Gayton more than 10 years ago for the correction of microphthalmia. Although initially described with the 2 lenses in the bag, the appearance of intractable interlenticular membranes led to the placement of the anterior IOL in the ciliary sulcus. But recent reports of anterior segment pigment dispersion have raised concerns on the use of this method of refractive refinement. According to Dr. Liliana Werner, the ideal IOL for piggyback implantation in the ciliary sulcus is one with smooth optical edges, flexible haptics, on a 10-degree angulation. In both of our cases, the piggyback implants were one-piece PMMA with rounded optical edges, but with rigid apex on a 10-degree anterior angulation. The reason for the pigment dispersion in case number 1 is likely due to the increased thickness of the piggyback IOLs, mainly the silicone lens, increasing the iris lens contact distance and consequently causing iris chafing. Compare the IOL thickness for different materials and same dioptric power. When we face pigment dispersion syndrome and the patients have normal intraocular pressure and no other symptoms as in case number 1, we have few management options. Watch closely, do a laser iridotomy, or do the piggyback IOL removal. In case number 1, we decided to perform a YAG laser iridotomy in an attempt to move the iris slightly forward. Accordingly, as demonstrated by UBM studies performed 15 days later, there was a slight deepening of the anterior chamber, 3.773 compared to 3.756 millimeters, as well as a minor decrease in the iris lens contact distance, 1.354 compared to 1.380 millimeters. Whether pigment dispersion is averted and eventual glaucoma development is prevented by laser peripheral iridotomy is unknown and await the outcome of long-term studies. In fact, Dr. Johnny Gayton is a strong advocate of peripheral laser iridotomy in piggyback lens implantation as a preventive measure against the risk of pupillary block. To confirm the long-term safety of piggyback IOLs with or without iridotomy, further UBM studies are necessary with longer follow-up and a larger sample. Thank you very much for your attention.